He's a guy who's kindly offered to come and talk to you guys today. These are the group who are involved in the course. Richard, at the back, I don't know if you can see, that's Dr. Saeed Qureshi. He's equivalent to yourself within this institute, and he's been responsible for facilitating these courses throughout. Sat to the left is Sajda. And you may have met her before when she come and visited our unit. And stood behind me as avoiding everybody is Sharia. So, my friend, what I've got is your presentation. I've enlightened them a little bit about it, and I'm just going to bring it up. And if you say next slide to me, then what I will do then is I will bring up the slide itself that you say. So I've got the first slide up, which is case presentation.
Okay, yep. So this is, we thought it's, with a lot of these teaching things, just to highlight a particular case and learning points from it is often a useful way of looking at things. So this is a chap who, if we go on to the next slide, Paul.
On.
It's a 64-year-old male who presented back in 2002 with anemia. At the time, he had a barium enema, so that just shows how things do change over the years. We don't do barium enemas, haven't done for a few years now, but this was standard practice back in 2002 at our institute. Showed a malignant lesion in the distal transverse colon. So we proceeded to laparotomy. One of the initial thoughts with this chap would be to do an extended right hemicolectomy, which we can discuss a little later if you wish. But at the time of operation, it was quite a bulky tumour that was adherent to the sigmoid colon. And so I proceeded to do a left hemicolectomy. So if we go on to the next slide, Paul.
Done.
That procedure went perfectly according to plan. He went into our surveillance programme, which for the first 5 years is essentially with CT scanning to check for metastatic disease. He did receive post-operative chemotherapy, and so our standard practice is CTs at 1, 3 and 5 years. And by 2007, he was all clear from that particular cancer. So we then proceeded on to our standard colonoscopic surveillance, which at the time we were offering colonoscopy every 5 years. So he had his first surveillance colonoscopy at the end of 2007, which was all clear, and a repeat was requested for 5 years later. So if we move on, Paul, please.
Done.
So in 2012, late 2012, we had colonoscopy, and this cecal polyp was apparent at that time. Next slide, please.
Done.
So the polyp was lifted, it was excised. Endoscopically, the excision was felt to be complete. Histology also showed complete excision with a low-grade tubulovolous adenoma. And again, according to our current protocol with the British Society of Gastroenterology guidelines, he had a repeat colonoscopy booked for 3 years' time. So next slide going, Paul.
Done.
So we're now early part of this year, so 3 years on. This is the appearance of his cecum at his colonoscopy in January of this year. I don't know if you want to point out, Paul, but yes, it is a sessile polyp, but one of the worrying things is there's a little bit of spreading to the left-hand side there as you're looking at the screen. So if we move on to the next slide again.
That's done.
The endoscopist, having performed that particular one, wondered if it was a polyp recurrence. Personally, I doubt very much if it was a recurrence. I think this is a new polyp. But he was rebooked for a therapeutic procedure, and I think this is where you first got involved, Paul.
It was.
Polyp was lifted. It was removed piecemeal, which, with the appearance of the sessile nature of the polyp, was almost going to be inevitable. The histology came back as a low-grade tubular adenoma. Again, with piecemeal resections, endoscopy was that it had been completely removed. And a repeat check of the site was arranged for a further 3 months' time. If we move on to the next slide, this is an image post-polypectomy, and you can see the mucosa being removed there, and the appearance is that the whole of the polyp has been removed. But because of the piecemeal nature, we did have another look 3 months later. Year, and there is a 12mm polyp, and this one probably will be a recurrence of that same polyp. But again, it was lifted, endoscopically completely removed, although again piecemeal, and arrangements were made for
Can you hear us, Richard?
if we can move on.
Richard,
Paul.
sorry, we got you on the 12mm polyp. It was lifted, and we asked for you to be present, and the histology showed focal high grade. Then we actually lost communication. Sorry.
Next slide.
Brilliant.
And again, that's a post-polypectomy image that we've got from that particular session. So if we move on to the next slide, and you should have now 17th of August this year showing a recurrence of the same polyp. Now, I'm not a great one for polyp morphology when it comes to endoscopy, but the appearance of this particular polyp, the vascular pattern looks a little bit more aggressive, it looks a little bit more injected. So slightly worrying features. If we move on to the next slide, we attempted at this stage to lift the polyp, but it wouldn't lift. And so again, the worrying feature with this, has it actually changed, had malignant change? The other thing to bear in mind is that if you keep removing a polyp and it recurs, then you will get scarring beneath the polyp, which again would prevent lifting. So they're the two things that may have happened in this case, but we felt that at this stage endoscopic removal was not going to be feasible anyway. So the area was tattooed and biopsied, and you can actually see on this image whereby with the tattoo and we've tried to lift it, the polyp has remained in its position. It hasn't lifted at all. So if we move on to the next slide, Paul. And this is one of the other issues which is, as a surgeon, and Paul and I have discussed this a few times before, actually understanding measurement, and I'll come on to this a little bit more, one of my bugbears. But we've measured here his original left hemicolectomy anastomosis is at about 30 centimetres from the anal margin. And the best way of measuring with a flexible endoscope is to actually place a finger at the anal margin on withdrawal so that you can get a fairly accurate measurement as to the distance, which can be very useful from a surgical perspective. The old-fashioned rigid sigmoidoscopes have 1 centimetre markings all the way along the scope. The flexible endoscopes don't. They have 10, 20, 30, as obviously you're aware. It can get, some of the measurements can get less accurate. So if we move on to the next slide, I'll come back to the measurement bit in a moment. But essentially now we've got a 78-year-old patient who is otherwise fit and well, has a polyp recurrence that's not endoscopically removable. We've already demonstrated high-grade progression within the polyp back in April. So at this stage, we decided that, come what may, whatever the histology came back as, the safest option for this patient with a progressing, recurring, non-endoscopically removable polyp in a fit person would be a right hemicolectomy. Histology, incidentally, did come back as malignant from those biopsies. So he underwent, next slide, Paul. So he underwent a right hemicolectomy early part of last month, and histology has come back as Dukes A. If we move on to the next slide, again, I've mentioned the importance of measurement. In this particular patient, elderly patients don't do very well with ileorectal anastomosis. So the longer the piece of residual large bowel you have, the better the function. And I felt that 30 centimetres would be a reasonably good length to perform a restorative procedure. And indeed, I have seen him back in clinic last week, and he already has pretty good bowel function, rather than having persistent diarrhoea, which can be an issue. And again, with regard to the measurement, one of the takeaway messages, hopefully from this, particularly involves rectal lesions. This is where it can be very, very useful, particularly with regard to preoperative staging and radiotherapy. In the UK, the standard thing that we perform for a rectal lesion, so anything within 15 centimetres of the anal margin, we would do preoperative MR staging with a potential view to preoperative radiotherapy based on the MR staging. I've recently had a couple of patients that at endoscopy it's been said tumours at 16 centimetres. We didn't preoperatively stage them, and at operation the lesion was in the mid-rectum, and the patients may well have benefited from preoperative radiotherapy. So just again, in summing up really, why do we perform surveillance? We've known for quite some time that there's a 10% risk at 10 years of developing a second lesion. So anybody with colorectal cancer, 10% risk at 10 years of another lesion. With the population getting older, we are now seeing more and more patients, and also with our treatment getting better, we are seeing more and more patients like this chap who are being cured of their initial cancer, but living long enough to develop another one. So we have now modified our colonoscopic surveillance over the last couple of years. We've now moved to 3-yearly colonoscopy rather than 5-yearly. The initial 5-yearly thing was really derived from what was considered by a group of peers to be a reasonable length of time, rather than it being based on population statistics. And certainly with the polyp guidance that we've got, the 5-yearly thing didn't fit comfortably with us. So we now check 3-yearly in our surveillance program, so long as the patient is fit enough to undergo colonoscopy. So if you want to move on 2 slides, Paul, because I'll put a blank one in there for no very good reason. So we now should be on to sort of the joint working. Paul and I now work quite closely together in a number of these situations. I think this patient provides a good example as to how joint working is part of an MDT approach, and also getting personalised care. There's a lot talked about this, and hopefully it is increasingly getting across that, yes, we do have guidelines for polyp surveillance as an example, but a guideline is a guideline. And what you have to do is apply that guideline to the individual person, the individual patient you have in front of you. And what applies to one person may not apply to another. And thinking back with this particular chap, my original thought with his first operation in 2002 would be to do an extended right hemicolectomy. If I'd done that, he wouldn't have been in this situation of a polyp recurring. However, at the time of his first operation, if I'd done an extended right hemiclectomy, that would have meant taking out the whole of his colon because of the adherence to the sigmoid. So we modified the case in his first operation, but we do have to take on board the risk of his current situation appearing. But then also we get into the situation of do we continue with colonoscopic surveillance when we have this cecal polyp, or should we have said earlier that, okay, he's got this recurring polyp, should we have done his right hemiclectomy back in April? Have to bear in mind that the mortality from a colonic resection across the UK is around about 3.5%. The disease-free survival from a Dukes A resection should be 98%. Okay, they're very, very similar percentages, but the risk of an operation is slightly higher than continuing with endoscopic surveillance. So these are the things that we often have to weigh up when we're considering a patient. And yes, use the guidance, but you have an individual in front of you as well. And that's really all I had to say.
Richard, thank you very much. What I'd like to do is that this is, the basic skills course, what we've got. We've got people here who range from not doing very many, a handful, to someone doing 200. The take-home message with regards it, I think sometimes is not to attempt to take off polyps that are beyond you. And I think the big thing is that you've highlighted is to actually how to assess it, size it, say where it is, and give an accurate interpretation. And if you're the surgeon involved, and I'm not a surgeon as you know, but if you're the surgeon involved, get the surgeon involved down so they can eyeball it. What would your comments be about that?
Totally agree with it. It's something that hasn't happened a great deal in the past, and but we've had MDT working within the UK. It really started back in around about 97, 98 when I first became a consultant. But one of the things that's missing from our MDT meetings is the patient. And that's one of the things that we're often critical with each other about, particularly with difficult cases. And we often say at the MDT meeting, at the end of the day, the MDT will come up with a decision, but it's up to the patient. And then I'm left face-to-face, one-to-one with the patient, when in actual fact, particularly with something like endoscopy and surgery, and okay, I'm also an endoscopist, as are my surgical colleagues, but like yourself, Paul, you have a lot more experience of polypectomy than I do, and therefore working together in a joint approach to get the right answer, I'm sure, is the better way forwards. Excellent. But we've also got the patient in front of us as well when we're doing the endoscopy at the same time. Assessing the lesion with the patient and discussing it with the patient at the time is, to me, a very good way forwards.
Excellent. I'm just going to ask, is there any questions from the floor? Saad? That's the CT scan, 1, 3 and 5. So there's a query about when you would still recommend CT scanning, Richard?
Basically, the CT scan is essentially looking for metastatic disease. The main focus of this talk really is the follow-on colonoscopic surveillance looking for metachronous lesions. Yes, sometimes we would also do a colonoscopy looking for anastomotic recurrence. I like to think that if we do a proper operation, you're not going to get anastomotic recurrence. And, in my practice over the years, it used to happen years gone by, but nowadays we do a much better first up operation all the time. And so that doesn't occur. But the initial CT surveillance is looking for metastases and potentially local recurrence if we didn't get in clearance at the initial operation. We do it at 1 and 3 years for patients that do not have adjuvant chemotherapy. But in patients that have post-operative adjuvant chemotherapy, one of the things that we have realised is that it can delay the metastases. Doesn't take away the metastatic issue totally. It can delay it. So that's why in post-operative adjuvant chemotherapy patients, we would do a 5-year CT as well as the 1 and 3. But then after that, it's felt that the risk of recurrence, the risk of metastasis is basically gone. So that's where we stopped the CT surveillance. If there's a clinical reason for a CT, then that's a different issue. But the purely surveillance one is 1 and 3, but in chemotherapy patients, 5.
Thank you very much, Richard. Yes, my friend. Yeah, what Richard's talking about is that he wanted you to really focus on the endoscopic surveillance. So we did have a question there, Richard, about tumour markers, but as I said to my reminder, Zia?
Yes, tumour markers are a very debatable thing. Things split into 2 camps by and large. In the UK, it raises its thing about every 5 to 10 years. People come up with the idea, let's do tumour markers. In the East Midlands, I actually initiated our latest surveillance guidance, and as part of that, we did decide that we would look at CEA as a marker of recurrence. Historic papers, a number of times it's been looked at, it doesn't make any difference. Hopefully in the next 5 years we may come up with a definitive paper. But it's, to me, tumour markers, the best use for them currently is to monitor treatment. So if you've got somebody with recurrent or metastatic disease, they've got a high tumour marker, you're giving them chemotherapy, yes, it's a good means of monitoring treatment. But as a diagnostic tool, I have to say I'm not a great fan. But I know that a number of people do use them.
Thanks very much. One more question.
Hello, Mr. Hine. I'm there. Nice to see you here. I'm honored to work with you in UK at the same center. I have a question. In UK, I've seen the patient in the age of 90, they're good performance status. So do you personally think that there should be some age limitation, or according to the functional class, at what age or what functional class we have to do the surveillance of polyp surveillance, or after the colorectal surgery, we have to do the surveillance? Like a patient with 90 plus, in UK, they have a good functional class, we do the surgery and we do the surveillance. But do you think that there should be, like in Barrett's, we don't recommend, BSG doesn't recommend surveillance after age of 75. So like this gentleman is 78. So for how long you plan to do the surveillance?
So Richard, what he's actually asking is that surgery has been performed when we found a cancer or cancerous polyps in patients who are fit and well in their 90s. Do you think there should be a cap with regards age, or what do you think the actual indicators are for not performing surgery in the elder populace?
Yeah, it's always a difficult one. That years ago, when we first came up with our guidance for this, we did have a cut-off of age 75, so we would stop surveillance at 75. We're not allowed to be ageist anymore. So essentially, we carry on whilst the patient is fit enough to undergo colonoscopy, and if the patient wants it to happen. So in these situations, we very much put it over to patient choice. And again, with surgery in the elderly, age isn't necessarily a barrier. But what we tend to do is to discuss with the patient the pros and cons of surgery. A large number of elderly patients decide they do not want an operation, even when they've got cancer, proven cancer. Some patients do wish to go ahead. As a generalisation, the older the patient, the higher the risk. And we have a lot of risk modelling, surgical risk modelling computer programs for us nowadays, but none of them actually take into account extreme old age. And the experience in our unit of even elective surgery in the over 90s is about a 50% mortality. We don't operate on many of them, obviously, but because not many patients come through at that age for elective surgery, but it is a high risk because they don't have the physiological reserve. And even if an operation goes perfectly straightforwardly, it is quite a stress to the system. So we basically base it on individual patients with discussion with the patient and usually their family as well. So yes, we do continue. We do operate in some older people, but it's we don't have an age cut-off basically.
Thank you very much, Richard. I think we'll call it quits there, and let's just say to you, thank you very much for taking out the time. You enjoy yourself.
You're very well.
And it's great to see you, and I'll see you back. Well, if you're making Jane's a week today, I sent you a text about Dr. Jane.
You did. Unfortunately, as an aside, we won't be able to make it because Alison's working.
Oh.
She's making sure the endoscopy unit continues to run in your absence.
Not a problem, my friend. You look after yourself. Thanks.
Okay.
Cheers.
See you soon.
Bye.
Bye.
So the message from there, really, I know that a few of you guys were asking us certain questions about tumour markers and CT scans, etc. But the main take-home message is to, when you see a polyp, don't just jump blindly into assessing it, into actually wanting to take it off. You have to take time, you have to look at it, you have to make the correct call. The correct call isn't to actually just go, lift, oh, it didn't lift there, I'll just lift the edges and then hopefully I'll be able to take off the centre. The call there was to actually take it forward and to actually get the surgeon concerned to get them to eyeball it. The histology came back from that polyp as just dysplasia, be it low grade or high grade. On the resection, it was then shown to have malignant cells within it. That wasn't picked up on the biopsies, was only picked up in the resection margin. And that the decision that the polyp had a malignant potential was by how it behaved. You're starting out in your careers, how a polyp behaves, you learn the more you see. And what we want you to do is, when you see a polyp, don't just go ahead and just want to chop everything off and chop everything out. One, it is not safe to do so. Two, you've got to know what you're dealing with, because you can actually cause more harm than good. Because if you bisect a malignant polyp, you have then caused major issues for that patient, and it goes from Dukes A. And if you perforate that patient with a Dukes A polyp, you've gone from Dukes A, Dukes D. You've actually sentenced that patient to a consequence. So take your time, don't rush, think, take pictures. You can always go back. Take counsel from your seniors and more experienced individuals. This patient wanted to avoid surgery. I've got another patient who we could have done the same. He's a guy who came and he had 40 plus polyps in his entire colon. He should have had his whole colon removed. Didn't want it. He was 66, very fit man. He went on, he had 3 colonoscopies with me in the space of 4 months. I took him in stages. It took me 2 hours to remove all the polyps in the right colon. It took me 3 hours to remove all the ones in the transverse colon, and 2 hours to remove all the ones in the left colon. I then repeated it every 6 months for the next 2.5 years. He's now got 1 polyp that's recurred in the right colon that's got cancer in it. He knew that it would eventually he would get cancer. He just wanted at all costs to avoid the operation. So the costs with us, it goes down to, as Richard went on in his presentation, to say about personalised care. If the patient doesn't want it in the UK, we can't force them. In Pakistan, you could actually sit down and talk to the family and leave it to the family to come back and chat with the, you know.
I was asking about was in MDTs, do people consider cost at all? Like,
Ah,
for example,
right.
if somebody is going that means if two options, the two pathways are available, and one you have to do serial endoscopy,
Yeah.
and both of them, like this patient had almost equal results.
Yes.
Isn't it?
Yes.
I mean, outcome-wise, both the
Yeah.
techniques almost had almost the same result. But in those situations, is at any time in MDT do you consider cost or not?
Cost is not the issue. The only issue in the UK is the cost of your drugs. That's the only thing that they talk about. The fact is that we'll follow a path of care. If that then fails, we'll jump to the alternative. But it's the only big thing that we all shout about is the cost of medications.
Cost as in what, like comparing cost of...
Multiple endoscopies, like when a patient who's got high risk of treatment, progression of disease, would have gone say up to 5 or 6 or 7 endoscopy procedures, and for example, in the last session, endoscopic session that you had, you could stop and when you're not able to lift up the
Yeah.
for the coming, I mean, let's say next 5 or 6 sessions, were you able to lift it up, you would have gone endoscopy.
I actually told him, which wasn't really, I said to him that the reason for inviting Richard to come to that one is I had a feeling it wouldn't lift. So we were going to make a definitive treatment option. If I was unsure that it wouldn't lift, but I had an inkling that it was going to do something and I could have teased it out, I've got him stood next to me, I would have done it, and then we would have took him straight to theatres. If the polyp didn't lift, which is what I felt that it wouldn't do, then he's there as the surgeon then to say, this is how we're going to manage it, and then we take him off. So when I've got a high-risk polyp, I always double book, as it were, so I'll get you down.
The point here is that if you give the patient an option of multiple colonoscopy, and if you had one, then you had a good experience. And personally, I would rather have my endoscopy done than have my collect. So why would I subject myself to a surgery when I can have something that's in competent hands endoscopy? And there the cost is not so much of an issue. The question is, do I want to be cut and do I want my cut to be removed when there is a possibility that I may get away with it? And if you give that option to most patients, the patients will make that decision. If you give the option patients to be, you have, there is a surgery saving procedure versus surgery, what do you want?
I think though I missed the discussion, but the main thing also is the histology of the polyp. Because if you got high-grade dysplasia, there's a 20-30% chance that it can metastasize. So you have to be cautious of that. It is a very well recognized way of removing polyps with high-grade dysplasia and in situ carcinoma. It goes through our MDT, and it should go through because it should be well covered and followed up. And especially polyps with high-grade dysplasia should have staging procedures also carried out. We normally do them with chest as well as a pelvic CT. And if it's a rectal lesion, we do an MR scan as well. But it is a very well recognized way of removing the polyp. It is very safe and it is less mutilated for everyone. So, and as if you are concerned it's a big polyp, there is a risk of complication, then it's always best to get the surgeon involved early rather than late. I think the surgeon is aware that you are taking it, because that's when we take our high-risk polyp out, especially those in which the excess of 30 millimeters, and we are concerned that it might cause a perforation or a major bleed, then I have my surgeon on standby and we do it,
Why do you have the surgeon stand by with you? What difference does it make if he is with you? Or if you stand by, like stand by?
standby.
It doesn't have to be.
Doesn't have to be in the department.
But normally what we do is,
When he needs to be
Yes.
He should know that I'm doing something serious and he should be available.
What I do in the morning, on Monday morning is my big polyps. And big polyps are 8 centimetre, 10 centimetre polyps, wherever in the bowel. I will find out who's on call. If it's Dr. Qureshi, I would then ring him up. I would say, I've got this polyp on today, and I'm about to take it off. He'll then tell me I'm rather busy today, and I'll, try to avoid it, and he'll give me a load of ribbing and joking not to do it, and then we'll go ahead and take off the polyp. It's a safety net that you need. The last thing he needs is me ringing him up and saying I've cocked up. He needs to know well before that I'm doing something. And the other thing is that you then, if they're unsure about your technical expertise, there's a lot of people who do these things whose technical expertise isn't there. Now, if he's concerned about your technical expertise, he may come down and say, well, let's come and have a look at it first, shall we? And then should we be dealing with it like that? And that is a way of actually supporting you. It's not a way of putting you in it's a way of supporting. And that's what I like, is that I let the surgeons know. They never turn up, but at the end of the day, it's there. If something was to inadvertently go wrong, and you know you can call on them. What we don't want you to do is just go blindly doing stupidity.
So, as I understand, you said you moved multiple polyps from my...
That was a different patient. Not this patient.
You move at one time in 6 or 9 hours and you move many polyps.
Not on this patient. On the other patient, yes.
It's not dangerous for that patient. If you move multiple polyps and you repeat after 6 months the same procedure and procedure malignant.
No, after just under 3 years, I removed all the polyps in his right colon, and just under 3 years, I went back and did a full colonoscopy again, and there was a small polyp in the ascending colon, which I had cleared just under 3 years earlier, and there was had a malignant potential. I knew just by looking at it, it was a cancer. Some people would have interpreted it as a flat lesion, but this was a definite cancer. He's had surgery. He didn't want surgery. The patient did not want surgery.
I think one thing very important is you have to give the choice to the patient. Give him the options available, and then obviously it's his decision. Some people would say, okay, fine, let's get. Let's have surgery. The difference between here, when you explain anything to the patient, there's some जो आप कहें वो हमारे लिए अच्छा है. ये डिपेंड करता है. आप हमारे लिए कह सकते हो. What's the our plan के बाद? You have to
give your sincere opinion, no?
Yeah, when you take a consent.
Irrespective क्या आपकी फीस में आ रही है या नहीं आ रही है, मतलब हम लोग का private वो नहीं होता.
I usually say, in my practice, I tell them, this is what I would do for my mother. Yes.
That is
This is what I would do for myself.
opinion now, you know.
If I had this cancer, this is what I would have done. After that, they don't ask anything. Or mother or sister or brother or whatever.
That is how it should be.
Once you answer,
Right, can we just do our next talk? This is Stephen Foley. He's the lead for gastroenterology at Kings Mill Hospital where I work. He's secretly looking for a way out. Not from the hospital, from being the lead. Because management in hospitals in the UK is a massive headache. I'm sure that lead guys here will also tell you it's the same here. But it's a massive headache. But he's taken time out. He wants to talk to you about what it's like to be the medical director of a busy endoscopy unit in the UK. Okay? His wife's a GP, and he's got 3 children. Egyptian. Good morning, Steve. Well, afternoon here, Steve.
Good morning
to you. How are you doing?
Very good, thanks.
Can't hear the boys in the background? The boys are being quiet.
They're, yeah, on the Xbox, no doubt. Great.
Right, Steve, thanks for taking some time out to chat to us. As you can see, we've got a fair few people in the room. On the front row, we've got Dr. Saeed Qureshi. He's the lead for the surgical unit here. and also next to him is Saad Niaz, and then also we've got Sajda, who you've met in the past, and Vakar. We've got a lot of observers and a lot of candidates. What I was going to do, Steve, is ask you to actually just tell us what it's like to run a busy unit gastroenterology service in the UK.
So it's an interesting challenge because over the last few years, gastroenterology has grown enormously in Britain. Our endoscopy service grew its activity by 17% last year. So all the time we're ramping up the volume and also trying to ramp up the quality and controlling the quality, the timeliness of how we deliver care at the same time whilst trying to invest in and develop our staff and increase the volumes. In a service and health service like many in the world where the financial constraints is very tight, means that you have to be very hands-on. And so it's a bit of a roller coaster ride, constant challenge, but it's exciting. And we do it by having a team that's tightly knit and works closely together.
Steve, can I just ask, if we were actually thinking about 5 years ago, how many lists would run a week in at King's Mill, compared to how many lists are running currently now or should be running now? And then if we look at a 5-year projection, how many lists would you expect to be running?
So I think we've probably doubled our activity over the last 5 years, and current national predictions are that we will increase round about 10% a year. So I suspect in 5 years' time will be another 50% more. So we're currently doing about 14,000 procedures a year through our unit, and that may be close to 20,000 in 5 years' time. Beyond that, who knows what technological changes will guide what we do, and maybe different fecal testing or blood genetic testing, liquid cytology type approaches may decrease or even increase the amount of endoscopy that we do. But in the short term, in Britain, there's a real drive to increase endoscopy for 2 reasons. Firstly, to bring earlier diagnosis of cancer, because that changes the treatment options, and particularly with colorectal cancer, diagnosis and removal of polyps. It obviously avoids the colorectal cancer developing. And these things on a massive scale make a huge difference in terms of public health and population survival. So it is a big conscious investment in our health system, and it is already paying off. The other thing that's different in the last few years is that we're having an epidemic of almost of inflammatory bowel disease, Crohn's disease, and ulcerative colitis. And the incidence is ramping up. That's not really understood. That is a worldwide phenomenon, but we're really experiencing that in Britain currently.
Steve, with regards to service in the UK, we don't just provide service to our patients on surveillance, patients that are seen in clinic. We also provide with patients who have come through different routes, such as bowel cancer screening and the bowel scope. How do you think the demand from that is going to cause pressure upon already busy units?
So the bowel cancer screening program has been a huge success over the last few years, and this is where we do fecal occult blood testing to patients aged between 60 and 75. And that's run as a screening program, like all screening programs in Britain, in a very tight, centrally controlled way to deliver on quality and safety. And so we've seen a big extension of that with the age extension a few years ago, when the upper age limit was added. And as the program rolls through, the increasing numbers of patients who are having follow-up polyp surveillance through that. The next stage of it is flexible sigmoidoscopy screening, where the entire population are invited for a one-off flexible sigmoidoscopy at the age of 55. And starting to roll that out. But you can imagine this is an enormous undertaking. And this is going to grow to us over the next year to an extra 7 lists a week of flexible sigmoidoscopy. And then that brings further colonoscopies where polyps are detected. And obviously the follow-up surveillance colonoscopies once the polyps have been removed. So over the next few years, this again is going to massively increase our need for colonoscopy. And so this is something that we have to really be planning for in terms of how we're going to expand our service. Not only physically, where are we going to do all these procedures? We need more rooms, we need more kits, and that needs planning. But also we need to think about the staff, who's going to do the procedures, how we prepare and train and invest in those, and how we're going to run the unit well, so that the staff are valued and working together as a sort of endoscopy community, and that we've really got a handle on quality.
Steve, the big demand as well is that we have to provide more endoscopy. One of the best ways of providing quality endoscopy is to provide a good monitored training system. Can you just give us a little bit of insight into how that would affect in providing training a unit, and what your views are on how training is in the UK?
So the providing, if we start just talking about how we can provide training in the unit and what the tensions are there, because obviously training takes time. You have to invest in people. You have to set time aside, not only reducing the activity on the left and putting the experienced endoscopists there supported to work with the trainees. So that is a constant tension when you're under pressure to deliver volume of activity in a timely fashion. But it's really important to look at it from the other. So it's really important to look at it from the other side and see the value of investing in the training. And that obviously pays off for the trainees, and that's your future workforce, but also for the staff who are doing the training, because not only does it deliver an extra aspect to their jobs and a more enjoyable aspect, and also it can improve their technique as well. But it also leads on to those softer measures of quality in the unit, both of the procedure quality, the safety measures, the patient experience measures, but also the more global team enjoyment of working together. So training in the UK, again, has been an evolutionary thing. And when I trained, it was very much get on with it yourself type approach with a certain amount of supported training. And I think we've moved very much away from that over the last 10 years, so that in my people, when all the trainees start in our units, we sit down and we identify a training plan, what list they're going to go to. We make sure that they've got access to the appropriate courses. And then we sit down quarterly and look through the portfolios of all the trainees in our unit and make sure that they're progressing along the plan and make that they've got the support. We speak with their trainers and ensure that things are progressing.
Excellent. Steve, can I just ask a question? With regards your week, how much clinical and how much time as a lead for gastroenterology do you spend in meetings?
How much do I spend in meetings?
Yeah.
So the total budget for the services that I run with endoscopy, clinical gastroenterology is currently around about £14 million a year. And so in a typical week, I would do 3 endoscopy lists, 2 clinics, probably a session of manometry. Normally in the NHS, management has got well rewarded, so I normally have 4 hours a week in a job plan, of which, of that 4 hours, I spend about 6 or 7 hours in meetings. And then obviously the most important thing though is the kind of shop floor management, the availability, the ability to spend a bit of time with the colleagues, picking up problems and working through them as they arrive, and making people feel invested in, and being a presence. So, popping down onto the shop floor on the unit, going to the board, and just acknowledging the staff working with them.
Excellent. Just one second. I was just going to ask, someone's got a question for you, Steve.
Did you say 14 million pounds?
£14 million, yes.
Does that include the salary, etc.? Or is
Does that of the £14 million budget that you hold, Steve, does that include salaries?
Yeah, so most of the number one expense in the health
Don't
service
say
in the UK, it's staff costs. So yeah, that includes that. But that's including the turnover for our gastroenterology service and our endoscopy unit.
Just give you an idea, I was just talking to say.
They're just one second.
Budget of civil hospital.
The budget of civil hospital,
2,000
2,000
beds?
beds.
Almost 2,000 beds.
Yeah.
Is $40 million.
$40 million. So
40 million. The budget for our hospital is around about £220 million, and yes, it's about 600 beds, and I think that represents the differential in staffing costs between our societies. Obviously, there's a big administrative and regulatory cost in the UK as well, which it's different. And now we have quite a large executive and administrative workforce in our hospitals, which leads to a different, sometimes challenging in the way we run things, because clearly the best service is one that's led and run by the clinicians.
So, Steve, just a few questions now, technical questions. Between ourselves and Newark, how many scopes approximately do we have?
How many scopes? So, off the top of my head, I think we have got probably about 14 colonoscopes, so running 4 rooms, and probably a similar number of gastroscopes, 15 or 16. And so this is running 4 rooms, and across those 4 rooms we are typically doing 10 lists a day. So around about 120 points of endoscopy a day.
Excellent. Any other questions? Steve, thank you very much for taking out the time. It's been enlightening to, I think the chaps just think that senior guys just attend a few meetings and then maintain to be clinical. They forget that you actually spend probably a third to 50% of your time in meetings and still expected to spend your 75% of your clinical time still being clinical. And they forget that 50% of it is actually 40% is being dragged away and it's only through your hard work, not through payment that you're receiving to do it. And that's it's not an irritating issue, but it shows your demand for being a manager of a unit and a service rather than allowing you to be a clinician. Are you there?
Yeah, thank you very much, Paul.
No problem, Steve. You look after yourself, my friend.
And we'll see you back soon, I hope.
See you soon, my friend. Bye. Right, Steve's gone. Now, the thing about Steve, he's very Old English accent, so you probably didn't understand a lot of what he was saying. What he was actually saying is that the unit itself, he manages. A lot of the time you have guys who manage, and Steve goes to a lot of meetings. He gets told from the managers of the hospital that he's supposed to impose X. He then comes down, then he comes to see me and he says, we need you to work this way. I say, yes, thank you very much. He goes back to his office and I continue doing what I'm doing. So hopefully those talks were enlightening. Richard, I think his talk was probably going to be a very good take-home message to you boys. I think Steve's is just really to give you insight that there's a lot more going on out there, and that our budget for our unit is 14 million just for an endoscopy unit. The budget for this hospital is $40 million, not 14 million pounds. So approximately half the budget for this hospital we get to run a unit, which is laughable. Okay. Tomorrow there are 2 talks. One is from Sharon. I have to remember her name, what she's going by. Hudson, because she's been married 3 times, or is it twice? I can't remember. So she's talking tomorrow. Tomorrow, yes. We're done for today. Hopefully those were enlightening, slightly different. Enjoy.
So it's only 15 minutes lunch break today.
Is that okay?
15